So I'm a sociologist at the University of Oxford. My name is Michael Biggs, and I spoke about puberty blockers and the history of where puberty blockers came from as a sort of a treatment for gender dysphoria, and scrutinized some of the evidence and found a lot of the evidence to be wanting for why puberty blockers are not. The evidence for their safety and efficacy is very weak, and so scrutinizing the kind of scientific medical literature on puberty blockers.
And my name's Az Hakim. I'm a consultant psychiatrist. I also trained as a forensic psychotherapist and a group analyst. I started working clinically in gender dysphoria 22 years ago, before anyone was really talking about it. I'm the only consultant psychiatrist in medical psychotherapy that specialises in psychotherapy for gender dysphoria. I've written, researched, published and seen patients for years without anyone really noticing, because I've mainly published in the academic literature. But ever since I joined Twitter and wrote a book, that's on Amazon, people do seem to know what I'm doing. So we were talking about how people with gender dysphoria are treated and assessed, and the focus on physical treatments, puberty blockers and surgery. And I was talking about how useful the exploratory therapy is, rather than just affirming and going along with it and giving hormones, and the concerns we have about physical treatments.
So in the United States, the medical health professional organizations, establishment ones, have been, the messaging they put out about puberty blockers is that the concerns and fears about it are unfounded, that any pushback is rooted in transphobia potentially, and that this is a safe option that parents can choose for their children. What do puberty blockers do?
Well, it's for males, it's literally chemical castration. Puberty blockers are the drugs that are licensed. They're not licensed to treat gender dysphoria, but they are licensed to chemically castrate sex offenders or men with severe sexual obsessions, as well as for some other conditions like prostate cancer.
What is a chemical castration?
It means it completely blocks the production of your sex hormones. So obviously, a man, you normally have lots of testosterone. You take puberty blockers, your testosterone falls to nothing, or almost nothing. So it blocks the production of testosterone if you're a man. If you're a woman, it blocks the production of estrogen. So it removes your normal sex hormones.
And why is that? Well, you raise alarm bells about this. You write that this is dangerous for children, right?
Yes, remember that this has never been licensed to treat gender dysphoria, so it's an off-label use of the drug. So there's never been any randomized clinical trial, and there's a lot of evidence that, particularly when it's begun early, that this leads to severe consequences down the line. For example, you create adults who can't orgasm, adults with no sexual desire, because obviously if you start at the very early stages of puberty, the child will never go through the normal process of sexual development that you go through in adolescence. Now that's a massive, severe consequence. And the question is, can a 10-year-old, and these drugs can be used in some cases 9 years old. I mean, that is unusual, but there are many cases.
But WPATH wants to lower it. They want to make it even lower. And we were saying, how can any child give informed consent for something which is going to result in them never having a sexually functioning adult life? They can't.
Do the views that you two take publicly and professionally on these matters, does that put you at odds with, the professional establishment here?
No, actually, it used to, but I think more and more now the NHS is coming around. The NHS has now got a proper review of the evidence, and it admits that the evidence for their use is very low. The CAS review, the CAS inquiry into transgender health is moving sort of very slowly but steadily in the direction of saying there are lots of problems with the way the automatic sort of affirmation that was in reign perhaps 5 years ago, was sort of maybe the orthodoxy 5 years ago. The transgender clinic here, the biggest child gender clinic in the world, has been shut down or will close shortly, precisely because of increasing concerns about the evidence for these treatments.
And also, as a doctor, when I talk to all my medical colleagues in all specialties, they all realise that this is a really bad thing. You have a very small number of doctors working in gender clinics, and it's only those small number of doctors who think it's a good idea. If you ask any doctor outside gender clinics, they're really concerned that you're castrating children chemically and then doing this surgical procedure. It's only the very small population of doctors who think it's a good idea, and they're very divorced from the rest of the medical practice. So, it doesn't make sense. If you've got a confused child, why don't you help that child by talking to them, helping them understand why they're confused? Why are they not happy with being a boy or a girl? When they say they feel like a girl, what do they mean? Don't just say, oh yes, you're born in the wrong body, your body is wrong, let's chemically castrate you. And we know that almost 100% of children who are chemically castrated go on to cross-sex hormones, and a lot of those will go on to have surgery. And a lot of them, if you left them alone would just be gay. So there's a huge concern that any sort of gender non-conforming kid would otherwise be gay.
Well, how come the medical establishment in the US seems, in my view, to not really allow these voices similar to yours to be discussed professionally? Do you agree with that or disagree?
I mean, there are a small number of activists who are saying that any questioning of the scientific evidence is motivated by transphobia. And then a lot of people maybe have their private suspicions in America, but they don't want to get involved because nobody wants to be called a transphobe. Nobody wants to be called, you're somebody who wants to harm trans kids. And of course we don't. None of us want to harm any children. We want to make sure that children go through the process that will give them the very best outcome. But when you have a small number of activists who can use this kind of career-destroying or reputation-destroying label of transphobia, that leads other people to be, and I'm afraid there are a lot of people who are cowardly and who just won't speak up.
And I am always saying that there's a huge proportion of people who present as trans who are actually on the autistic spectrum. And the autistic mind has a very black and white way of thinking. So, if you're not a certain sort of man, you must be a woman. If you're not a certain sort of woman, you must be a man. And the autistic mind is very black and white in terms of, well, if you either agree with me or you hate me. So if you don't agree with what I'm saying, then you must hate me, be phobic, be transphobic. So any dissent or critique is viewed as transphobia. But if you could say, well, what if you do nothing? The do nothing approach will probably result in a massive tsunami of post-operative regressors. We've seen, if there's an 8,000-fold increase of kids now going down this route, then the small numbers of regressors that we see now in 10 years' time will be huge. So it's whether you want to be on the right side of history or not. When I ran a therapy service for gender dysphoria, 26% of my patients were regressors, and all of them said, we wish someone had just explored with us why we thought what we thought. All we got were people agreeing with us. If only someone said, what do you mean? What do you mean you think you're a woman? What does that feel? They said, what we're having now in the therapy with you, if we had that at the time, we wouldn't have done something which we now regret.
In the US, a number of highly respected medical institutions, hospitals, children's hospitals, have come under fire by conservatives over performing surgery, what they call gender-affirming surgeries. Do you think what those medical institutions are doing is unethical?
I would say yes, because you can't operate on gender. Gender is a social construct. You have biological sex, and you can't change sex. All you can do is rearrange someone. So famously, Dr. Georges Bourreau in Casablanca, the first surgeon ever to do sex change operations, he said, I don't make men into women, I make men look like they have female bodily parts. But we've gone into the idea, and it's this fantasy idea that we can change sex surgically, and it's this magical reality, but it's not. It's a falsehood. So I think we definitely shouldn't be interfering with children's bodies. They aren't able to make informed consent. And with the adults, what are we really doing? Why aren't we just trying to work out why they're presenting like this? And if I look at my population of patients that I treated, just by helping them think, talk and understand, the outcome wasn't to stop them wanting to do anything with their bodies, but less than 2% of my patients actually wanted to go ahead with any physical stuff because they're actually happy with themselves. Once you'd thought about gender and why it was so important and so troubling to them, and I would do it in a group, so the therapy was done by different people with gender problems themselves, they worked out how they'd ended up here rather than here, and they were happy with themselves. Less than 2% wanted to physically do anything.
What do you think, Professor Biggs? Is it unethical what some of these very well-respected medical institutions in the United States are doing?
I certainly think puberty blockers should not be offered unless it's part of a proper, rigorous clinical trial. And I know we disagree.
I don't think a child can give informed consent.
We disagree about this. I would say pragmatically that we have a large demand for puberty blockers. So in some sense, if we don't give them as part of a clinical trial, then people are going to go and get them illegally. But certainly, I think any kind of irreversible intervention under the age of 18, I think we have to be very wary of. And I think what makes me particularly suspicious is that these gender clinics do not carry out longitudinal studies of their patients. They don't collect the data. So let me give you a very concrete example. The first pediatric gender clinic in America was founded in Boston Children's Hospital in, I think, around about 2008, and they used the Dutch protocol and they brought in puberty blockers. They were going to do a study of their patients, which would parallel the Dutch study and then the study that was done in the Tavistock Clinic. They never produced any data. They never collected any data. So this is now hundreds of patients who have gone through this process of having puberty blockers, but Boston, apparently, Children's Hospital have no clue what happened to them, whether the results were good or bad. Certainly haven't released that data publicly. And I think the suspicion is, if they're collecting, they probably are collecting that data, why have they not published it? They probably have not published it, as I discovered in the Tavistock, because the results were not promising. And this is one of the aspects of my research. I discovered that the Tavistock was actually hiding the results from their experiment with puberty blockers because the results were not the sort of good results or superficially good results that you found from Amsterdam.
For an international audience who's not familiar with the Tavistock Clinic, can you explain what that is?
So the Tavistock is a large psychotherapy clinic in Britain. It's the largest psychotherapy-only clinic. And within that clinic, there was a very small department that treated children for gender dysphoria. And that what started as a very small department grew like a tumour and took over the whole. Most of their money was coming from that. So people now. Tavistock has become synonymous with child gender stuff, whereas 20 years ago when I worked there it was a very small proportion. Coming back to the data outcome, what I found out was there was no real way of measuring how successful you are in treating gender dysphoria. So 10 years ago in Australia I had a research team and we devised a clinically valid and reliable tool. It's called the Gender Preoccupation and Stability Questionnaire, the GPSQ, and we published it in the International Journal of Transgenderism, and we showed that it's a valid, reliable tool. It's a 14-item questionnaire. It takes about 10 minutes to do, and it detects gender dysphoria, and it detects how comfortable you are with your gender and how stable you are in it over time. It's not restricting to male or female, or how male you are, how female. It's just how comfortable you are with your gender. So it can be with any gender. It can be with genderqueer, trans, whatever. It's how happy you are and how comfortable and stable you are, which other tools didn't measure. So we wanted it to be useful for everyone. So it's valid and reliable. It's used in the Southern Hemisphere because we devised it in Australia. I came back, and the Tavistock Clinic, who's being critiqued for not doing this outcome data studies for their child clinic, I wrote to them several times, publicly and privately, saying, you're tasked to get data, collect data. You're going to have a tool. This is one that I prepared earlier, and it's been researched, it's validated, it's reliable, we've published it. You can use it for free. It doesn't cost you anything. It's simple to use. They have not once responded. I'm not asking for any money. I'm saying, look, I've done the homework for you. They don't want to collect data. I've done the work for them. They're not interested.
Why is the gender clinic at Tavistock shutting down?
There was a review by a paediatrician, Hilary Cass, that was tasked by the government due to quite a a number of concerns from people who blew the whistle on the concerns of how the clinic was operating, to review how the clinic was operating. The CAS review didn't say the clinic needs to be shut down, but it pointed to a number of very significant concerns as to what was going on, how the children were being assessed, how fast they were being fast-tracked onto these hormones, and the fact there was no evidence for the treatment. And as a result, the NHS, the National Health Service of the UK, shut the clinic down.
So one of the ideas is to make, instead of gender being in this kind of silo that Az was talking about, that it will be distributed across a lot of hospitals which have expertise in, for example, autism. And so a range of different, because a lot of kids who come to the gender clinic might have other issues like being bullied, being autistic, being depressed, being anxious.
They all have other issues.
Right, and so those other issues can also be dealt with rather than the single-minded obsession that obviously if gender, it's like if you have a hammer, then everything looks like a nail.
The National Health Service in the UK is so stretched that and child mental health is exceptionally stressed. So when you've got an overstretched resource where a child has multiple mental health problems, as soon as they say the magic word gender, the child team goes, great, we can send them off to the gender clinic, and all their other complex problems, their autism, their trauma, their PTSD, all this stuff gets completely ignored, and it just becomes a gender thing. So you've got all these self-harming, traumatized, whatever it is, patients that are just having gender reassignment interventions, and everything else is ignored.
Thank you, gentlemen, for your time.
Thank you.
Thank you.